So first off, I'd like to just thank you all for giving me the opportunity to talk to you tonight about digital dentistry. So my main goal this evening is to ignite an interest and passion for digital dentistry via tonight's topic of digital diagnostics in endo. So thank you for taking the first step with me by attending this hour-and-a-half session. We'll try and stick to time. So often when we have an idea to start something new, the idea doesn't always come to fruition and often goes by the wayside. So individuals and businesses often have many ideas that fail, as well as some that succeed. So if you look at digital technology companies like Microsoft, for example, they had the idea of a tablet PC. Their idea was there in the 90s, but they didn't launch it until the year 2000. And their first unit failed because it was clunky and the advantages were outweighed by the technology sort of limitations of the time. But the concept that they'd had really did have potential. And we now know that sort of 10 years on from then, Apple launched the iPad in 2010 when they took over this idea that Microsoft had had. And they were just so successful with it that, of course, the iPad has created its own market for tablet computers. And in fact, it probably changed how other types of PCs, such as laptops and everything, are actually manufactured and marketed today. So I don't know about yourselves, but that whole kind of tablet laptop hybrid PC that's become so popular is certainly something I've adopted to use. But if we go back to dentistry, which is obviously what we're talking about tonight, what I want to walk you through is the digital environment, how it looks today after decades of innovation surrounding 3D digital imaging, and also introduce you to someone who can talk firsthand about their digital journey in dentistry. So if we have a look at our agenda for this evening, some of the topics we'll be covering, amongst other things, is going to include some market research and some studies into why now is the time to be investing in digital technology in your practices. And then we'll be handing over to tonight's guest speaker, who will be talking to you about her experiences with digital imaging and how that full digital diagnostic workflow is helping to achieve a better treatment outcome. We're also going to cover some topics and some questions for you to ask any manufacturer when you're looking at options available to you to invest in your practice, as well as how software can be used to assist you in the practice alongside that hardware. And then we're also going to be having a brief look at how Dentsply Sirona can partner with you on that journey. And then towards the end of the evening, we'll be handing back to our guest speaker, who'll be sharing with you something very new and exciting that she's been involved in. And then before we finish the evening, we'll be having an open questions and answers session, as well as going over and answering any questions that you've posted in chat throughout the evening. So feel free at any point through the evening to pop your questions in the chat. My colleague John will be keeping an eye on those and collating them for later on. And you can also raise your hand if you need to get John's attention for anything during tonight's hour-and-a-half journey. So let's start off by introducing who's going to be on tonight's session. So first up is myself. So I'm Adam Cartwright, your host for this evening. And I'll be taking us all on this exciting journey. So I'm one of the digital imaging specialists at Dentsply Sirona. I've been working in the industry for 30 years now. And I know, yes, you probably are all looking at the photo and looking at my video going, it's never 30 years. It looks like more like 50 or 60. It is only 30. And 27 of those have been working with sort of dental digital imaging, with the last 2.5, nearly 3 years now being here at Dentsply Sirona. Then our guest speaker tonight, I'll be handing over to Dr. Kreena Patel, who, although probably needs no introductions to most people on the call, I'm going to anyway. So Kreena is joining us. She's an endodontic specialist who spent 5 years teaching on the renowned specialist endodontics program at Guy's. And also, since Kreena became an expert in the field at King's College, she's gone on to become a pioneer in using technology to improve endodontics, and she also delivers lectures and courses on the subject, including tonight. And then finally, the last member on the call tonight, so finally but by no means least, will be my colleague Graham Parker. And later on tonight, he's going to take us through a short software session on how that works alongside the hardware in your practice, and how the software and hardware combined is going to give you all the tools you need during this digital transformation. So that's the three of us that are on the call tonight, obviously, and a couple of people on the backup team as well. So why is now the time to be investing in digital technology for your practices? We can understand, what's currently happening in the industry by observing industry trends and also by looking at studies that are being carried out. So it's important for the strategy of any practice owner to recognise where our industry and our business currently is, and also where it's heading. So things like what equipment are clinicians purchasing and intending to purchase, and the benefits around the latest technology. Now, these questions have already been asked on a large scale. And the first thing we're going to look at tonight is a global study that was conducted by us in our largest markets. So that includes key areas like the USA, Germany, and Japan. And that's come up with some interesting information. So of the 900 or so dentists who were asked about 5 main developments within digital dentistry, which was most important? And it's kind of no surprise that we can see there that the top 2 most important developments were intraoral scanners and 3D imaging. And when you look at how these 2 tools can work hand in hand with one another across just about every dental workflow, it becomes obvious why it's the biggest growth area, both recently and also in the coming years and at this moment in time. Now, that was via our global study, but if we also start to think about things more locally, then we can look at a study carried out by Private Dentistry UK. Now, they mirrored a similar sort of set of findings, and what they found was that 58% of dentists who completed their survey in the UK said they can see themselves carrying out more private treatment in 2021. Now, it also then comes as no surprise that based on that, 52% intend to invest in some kind of high-tech equipment during the next year to help them deliver that increase in private treatments. And we'll see there again, sort of digital intraoral scanners and digital imaging are up there as the top main purchases planned for this year ahead. And they're all tools to help with that delivery of the extra private treatments that are coming along. Now, what we can also look at is, as well as the market insights and see what's happening within the industry, obviously we can look at clinical studies. Now, when it comes to the key benefits of latest technology, some of the headline benefits include things like a more reliable diagnosis of atypical anatomy, as well as more predictable treatment plans and more consistent results, and that sort of extra clinical confidence that you gain from knowing more and that technology is helping you to achieve. So if we look at that in more detail, the 3 key things which come from these clinical studies are a highly reliable diagnosis of apical lesions, including atypical anatomy. And if we look at what the survey actually had to say, then it tells us that CBCT imaging reduces the risk of missing apical lesions by between 28 and 38% compared to using just periapical images alone. That's a massive, massive sort of improvement there. Now, the second point that was highlighted by the study was how CBCT helps you guys diagnose fractures with more ease. And what they actually found from that was that the mesiodistal fractures were only visible in 8% of cases, and buccolingual fractures only in 51% of cases when using intraoral images alone. But the great thing is that by adding in sort of more modern technology like CBCT, those rates are increased up to 64% and 87% respectively. So to be able to go from 8% to 64 is absolutely incredible. And I can't wait to see later on sort of some of these cases in use with Kreena. Now, the third key one, which comes up on a number of studies, is obviously being able to identify the hidden root canals during treatment. Now, what the studies show us here in terms of statistics is that, again, using periapical intraoral images alone failed to diagnose one or more additional root canals in 40% of cases. And 40% is an absolutely massive, massive number. So again, it's going to be really good to see how the technology is going to help us. So that's how the sort of the clinical studies as well as the sort of business studies are showing us what's going on within dentistry today and in the short-term future. Now, the next topic we're going to cover is how digital imaging is working within endodontics itself. And for that, I'm actually going to hand over to our guest speaker tonight, Dr. Kreena Patel, for the first of her two topics she's going to be discussing with us. So in a moment, Kreena's going to share her thoughts and insights with us. While she's doing that, remember to keep those questions coming into the chat. You'll also be able to ask your questions later on in the Q&A session, and that's going to follow Kreena's second discussion with us tonight, which is something quite exciting that I'm looking forward to hearing all about. But for now, I'm going to hand over to you, Kreena.
Thanks, Adam. It's great to be here, and I just want to start by thanking Dentsply Sirona for, really inviting me to be here to talk about this really interesting topic. So just to start with a little bit about me, I'm mainly a clinician, so I work in specialist practice in South London and in Reading, and this is my room. So for most of my cases as an endodontist, I use a microscope. And the introduction of the microscope was really a game changer into endodontics, because with a microscope, we're able to see very complex anatomy. And if we can see it, then we can treat it. And really, cone beam CT has had a similar impact on endodontics, because again, we can take images, really detailed images, and being able to now see that anatomy that's going on before we even open a tooth means that we can treatment plan far better than we've ever been able to before. So I think it's a massive, had a massive impact in what we're doing at the moment. I also do a lot of teaching. So I've only just recently left this post, but I was a senior clinical tutor at King's College London. So I taught on the specialist program that we have there. It's a fantastic program for anyone that's considering specialist training. I also do a lot of private education, and this is a course that I ran for Dentsply Sirona actually, on Protaper Next and Wave 1 Gold. So the aims of tonight are really to look at the applications of cone beam CT and endodontics, and I'm hoping to run through some cases with you just to really highlight the difference that cone beam can make to your practice. We're going to also be talking about the advantages and disadvantages of cone beam CT. And cone beam CT has been used for, it's not a new thing. I mean, it's been used for endodontics for many, many years now. And there's a really solid evidence base for its application into endodontics. So, sorry, I'm just going to close this bit. So why do we need cone beam CT? Well, the first thing that we need to look at is what are the problems with radiographs. So the first thing is it's a two-dimensional image, which gives us reasonably good information in the mesiodistal plane, but it gives us quite limited information on the buccolingual plane or the buccopalatal plane. So if we have a look at a case together, this was a patient that I saw, and she was referred to me for the root canal retreatment of this upper left 1 and the upper left 2. So for me, I looked at it and I thought, okay, it's a fairly straightforward retreatment. And I explained to her sort of this is the rough success rate, things like that. And then when I opened the tooth, there was 2 large buccal perforations that we can see here and here. So this was a complete surprise to me. I didn't have a cone beam CT of this tooth prior to treatment, and I really was surprised by this. And it would affect quite significantly the success rate. So although they had these perforations, I repaired them and we did, this is a 6-month review radiograph, and you can see that the lesions are healing nicely. But if I had this information prior to treatment, it would make a sort of significant difference to us. It also gives us limited information on where our teeth lie to important structures. So if we look at this case here, this is a lower left 7, extensive distal caries into pulp, and you can see that the base of this tooth lies very close to the ID canal. So on a 2D radiograph, I don't know if that canal is, very, very close, or if it's buccal, or if it's lingual to this tooth. And actually, it makes a big impact on treatment, because if we get any sealer or GP beyond the root, it could have a significant impact on the patient's paresthesia, temporary or permanent paresthesia to their lip, chin, or tongue. So really having that knowledge prior to going into treatment really helps with the consent process for these patients. And similarly for things like the mental foramen or the sinus, we really want to know where these teeth lie in relation to these structures, so we can carry out root canal treatment safely. So the other limitation of radiographs is geometric distortion. So if we look at this first case, treating and treatment planning this upper molar tooth would be really difficult, because we have no idea what sort of anatomy is going on in this area, purely because the roots are slightly curved. So on a 2D radiograph, we're seeing them, it's completely distorted. We have no idea what we're going to be handling. Similarly, when we have the palate, it can cause elongation and real problems in terms of sort of really visualizing that anatomy there. The other main problem with radiographs is anatomical noise. So anatomical noise is anything that overlies the structure that we want to look at. So in this case, we've got the sinus and the zygomatic buttress, which is completely obscuring the root apices of this tooth. The mesio-buccal canal has a significant curvature, and I really wouldn't know that looking at the 2D radiograph before I started. Also, you can see that what an importance an apex locator is here, because we just have no idea in terms of the length of those canals. The other structures that can overlie teeth that we want to look at are things like the ID nerve or the mental foramen, in the lower mandible, the submandibular fossa, and we know that the buccal cortex is very thick as well, and that can obscure the anatomy that we're trying to have a look at. So what a cone beam CT does, it allows us to have 3-dimensional sort of images of these structures. So we get a sagittal view, which we can flick through like this. This is the Dentsply Sirona software that I'm using here, and this is sort of the endo version of that software, which I'm sure Graham will talk through later. But I can sort of flick through the axial view and the coronal view, and I can see exactly what I'm dealing with in 3 dimensions. So it sort of gives us a whole new perspective before we even attempt treatment. So the benefits of cone beam CT. Well, cone beam CT was launched in the 1990s, so a long time ago. It's very well established. It gives us 3-dimensional views, like I talked about. It's very easy to manipulate, although I have to say you have to have good software in able to sort of manipulate this properly. And Dentsply Sirona, the software, I have to say, is very, very good for endodontic purposes. It's non-invasive, which is a really big plus, because, for example, if a tooth had a fracture before, we might need to surgically investigate this, or numb the patient up to actually clinically investigate this. with cone beam CT, we can actually look at these things without actually doing anything to the patient. So it's a fantastic way of looking at things without touching the patient or causing the patient any problems at all. We also get an accurate measurement of distance. So cone beam CT is shown to be precise in its linear and volumetric measurements to within 0.5 millimeters. So it's hugely accurate when we're working either surgically or doing root canal treatment in itself. Now, this is the position statement that was launched by the European Society of Endodontology, and it really discusses the main points that we use cone beam CT for in endodontics. So I'm going to be discussing all of these points in slightly more detail and giving case examples of each one. So the first thing that cone beam CT is beneficial for is the diagnosis of periapical lesions. So if we look at a case together, this is a patient that presented to me for root canal retreatment of the lower right 6. You can see it's a very complicated case right from the outset. He's got a fractured instrument in the mesial canal. He's got amalgam particles in the mesial canal as well. And he actually had no symptoms whatsoever. The main reason he was referred was because this tooth required a cuspal coverage restoration. So for me, it's really important as an endodontist to know how important is it to remove or to bypass that instrument. Now, from the PA radiograph, we can see that there's no obvious periapical lesion at all. But if we look at the cone beam CT, you can see right there on the sagittal slice, there's a distinct periapical lesion on the mesial root. So that's the first piece of information I know. I know that actually periapical radiograph, no lesion, CBCT, it shows a lesion. And if we flick through it, I can actually see exactly where the instrument is as well. So you'll see now I'm flicking through the axial slice. I can see the instrument is in the mesiolingual canal, and that's the canal with the lesion. So immediately I know that I need to remove this instrument or I need to bypass it in order for this case to be successful. The other important information I know is that the mesiobuccal and the mesiolingual canal are not joining together, which means, again, I do need to remove the mesiolingual instrument. So it's changed my perspective on this case and definitely changed the treatment plan that I feel that I need to approach the case with. And there is a lot of evidence for this. So we know from all the studies that cone beam CT is significantly more accurate in detecting apical periodontitis compared to radiographs. And this study gave us some really good insights. So what they looked at was they compared cone beam CT, periapical radiographs, and the histology of cadavers. So they had fresh cadavers, took a PA radiograph, they had a look, is there a lesion or isn't there a lesion? Then they took a cone beam, is there a lesion, isn't there a lesion? And then they compared it to the actual histology of what happened in that cadaver. And what they found was CBCT had a significantly better sensitivity compared to periapical radiographs. And you can see it's quite significant, 89% compared to 27%. Now, if we had a parallax radiograph, that did improve our detection rates for AP. So that was 38%, but nothing compared to what a cone beam CT shows us. So if we look at another case, this was a really interesting case, actually. It was a patient that presented with pain on their upper left quadrant. So they had pain with this sort of area here. And if we had a look at the clinical examination, the patient couldn't actually tell us where the pain was coming from, but the upper left 6 was tended to percussion and the upper left 7 was tended to percussion. On the OPG, again, we can't really see anything significant, no obvious lesions that sort of are visible on the radiograph. So if we had to guess, I would guess it was probably the upper left 6 that was causing symptoms. We can see that it's a heavily restored tooth. There is some sort of post within the root canal system, and there's no root canal that's been done whatsoever. The 7, on the other hand, it has a reasonably moderate sized restoration in it, but it looks fairly far away from pulp. So my initial treatment plan, without any sort of further diagnostic information, was let's take apart the 6 and do the root canal treatment for this tooth. Now, luckily, I had a cone beam CT on hand, and if we look at the cone beam CT, you can see that the lesion is actually fully associated with the 7. It's actually a massive lesion. We didn't, there's no way we would have seen this sort of size lesion on the radiograph, but it's quite significant that we couldn't see it. And the 6 actually has 0 lesion whatsoever. So the treatment plan here again has changed significantly. I'm now treating the 7 rather than the 6. And that does make a big difference, because if I had dismantled the 6, actually there's a high chance that tooth would no longer be restorable and the patient would be losing that tooth. So it significantly altered my treatment plan. And you can see it on all of the views here, a huge lesion associated with the 7, no lesion whatsoever with the 6 here. And if we look at another example, this was a patient that was referred to me for the root canal treatment, the endodontic surgery of the upper left 5 tooth, so this one here. Now, her history was she had the root canal treatment done abroad, followed by a post and a crown. And the dentist that she saw abroad said that when she gets back to the UK, her dentist should refer her to an endodontist for the surgery of this tooth. So she came to me. She was a reasonably paranoid lady. She didn't want any infection in her mouth. She takes care of her teeth really, really well. And she was like, Kreena, can you please do the apical surgery? That's what I've been told to do. And I looked at the periapical radiograph and I didn't see a lesion. So I said to her, okay, there's no obvious lesion here. Let's take a cone beam CT so we can make sure, just to put your mind at rest. So this is the cone beam CT. And you can see as we flick through the slices, there is no lesion whatsoever associated with the 5. This is the border of the sinus here and the membrane that we're seeing here. And again, no lesion with the 5 at all. Relatively, the sinus membrane is the same thickness throughout. So it's not, there's sort of no inflammation that we're detecting there at all. So in this case, it's actually made me think, change my plan from, instead of treating this tooth, I'm now going to tell this patient, you don't need any apical surgery. There's no obvious infection associated with this. Let's just monitor it. And she was, more than happy to do that once she'd seen the cone beam CT results. So it helps us be less invasive as well. It's also good for complex root canal treatment prior to retreatment. So if we look at, complex root canal treatment prior to root canal treatment. So if we look at this case here, it's difficult to know in endodontics what is complex and what isn't, because any tooth could really be complex. But upper 6s in particular, we know that nearly 90% of them have an extra canal called the MB2 canal. And this sort of imaging really helps us detect, is that there or is that not there? So we know whether to look for it or not. And you can see here, this is the MB1 canal and this is the MB2 canal. So this tooth definitely has one and we need to treat it. If we look at another case together, this was a lady that was referred for the root canal treatment of the lower left 7. We can see immediately on the periapical radiograph, this is a complex tooth. We've got significant curvatures on the mesial canals. And I was sort of a little bit worried about the treatment. So the first thing I thought of was, let's take a cone beam CT to look at this anatomy in more detail. Now, in terms of her symptoms, she had a crack as well inside this tooth. So she had pain on biting and pain on release of pressure. And this is what's led to this irreversible pulpitis that she has. So the first thing I wanted to do was have a look and see, is there a crack present in the tooth? And clinically, I could see that there is a crack here. But when I took my preoperative CBCT, I can also look and see if there's any distal bone loss associated with that crack. And that will help me know, even before I treat the tooth, if this crack has extended into the root. So if we look at the cone beam CT together, this is some slices that I've taken. And we can see firstly the significant curvature of the mesial root. I can also see that there is an extra distal root present, which was totally masked on the periapical radiograph. I can see that the position of the ID nerve, because that is fairly close, and you'll see when I go down again that the ID nerve was very, very close and it wound between the 2 roots. So I know I need to be a little bit more careful here. I can also see that the 2 mesial canals join together apically, and that's very useful information to know. So the information gained was that firstly, there was no distal bone loss associated with the crack. So although the crack may have extended into root, it's less likely to have done so. There was no periapical radiolucency associated with the tooth. So, worst case scenario, if I'm not able to negotiate these canals right to the apex, probably it's not going to cause a problem because it's a vital tooth without a lesion. I can see exactly what the canal curvature is like prior to attempting treatment here. I can see that there is an extra distal root, so that's what I need to look for when I do the root canal treatment. I can see that the mesiobuccal and mesiolingual join together apically, so that therefore I'm going to prepare the one that's easier to prepare first and then prepare the harder one afterwards. And I can also see that the ID nerve runs between the roots and is quite close to the distolingual root. So it's really changed my approach for this case. It also helps us for really complex anatomy. So this case is a dens in dente or a dens invaginatus. So a tooth within a tooth. And you can see here, this is the invagination, and this is the root canal that's sort of wound around the invagination. So prior to even thinking about treating a tooth like this, we need a cone beam CT. So these were the slices, and we can see here the invagination. We can see that, very similar to what the periapical radiograph shows, the canals join together at the top here. But look at the axial view. I can see that there is an invagination here, but the root canal wraps completely around that root canal. And that really, changes my management. I know exactly what I'm looking for when I go and do the treatment. And this was the final result. So I did the root canal treatment. And if we look at what we could see, the first thing I do when I dropped into the invagination was I can see the enamel, and you can see here, this is the enamel. The cone beam CT then guided me in a little bit further, and I know if I drill through that, I'm then going to face the root canal, and then I need to join that area together and fill it. So step by step, the cone beam CT really walked me through the case. I probably would have felt quite lost actually with that case if I didn't have a cone beam CT. It's really, really important for complex root canal treatment. It's also good prior to root canal retreatment. So if we just look at these two cone beam images here, firstly to start with, the first is a cone beam CT of an upper molar tooth, and we can see immediately there is a missed MB2 canal. So the mesial root, really things should look symmetrical. So if this MB1 was bang in the middle of the root, I wouldn't be worried that there was a missed MB2 canal. But here, there's a big asymmetry. There's definitely a missed MB2 canal here. And similarly, on this lower molar root, there is a missed distolingual canal here. And it gives, it's really good because I can immediately tell the patient there is an obvious cause for the problem of why this root canal has failed. And I know exactly what I'm looking for when I'm going and attempting treatment for this. This was a patient that saw my dad many years ago for the root canal treatment of these teeth. He presented probably, I think, about 8-9 years later with a huge buccal abscess associated with the lower right one. He had a crown on the tooth, which was done afterwards, and no obvious pocket. So he wanted me to try and save this tooth. So the first thing I thought of was to do a cone beam CT. There's no sort of real obvious reason why the root canal has failed. Both the canals have been found. You can see here there's a buccal canal and a lingual canal that's been prepared. I couldn't see a pocket, so I wasn't really thinking about a fracture at this point. I thought maybe this tooth has a cyst and I'm going to need to do some apical surgery. So that was my initial outset. I took a cone beam CT, and what you can see here is a huge fracture that's running through the tooth. And we can see on all the slices, it's a complete fracture right to the apex. And I would have expected to find a pocket in a case like this because, usually when you have cracks in teeth, you get pockets. But I think what's happened here is the fracture started apical and has wound its way up coronally. So immediately I know, without sort of investigating this any further, without raising a flap or doing anything invasive to the patient, that this needs to be extracted. So my treatment plan, again, has significantly changed because of my cone beam CT. Now, there is some evidence that cone beam CT can detect fractures in teeth. But that really is only true for big fractures. So similar to the one that I showed you, we can see large fractures with a cone beam CT. However, fine fractures we can't see. So if a patient has a very hairline crack in a tooth, don't expect to see that on a cone beam CT. It is a big limitation for cone beam. One of the main problems with cone beam is that you do get beam hardening. So when you have a root canal filling present, you get this starburst sort of vision that I'm going to show you in the next slide. And that really obstructs any fine fractures. And cone beam CT doesn't really have the resolution to pick up very fine fractures. So this was a really interesting study. It was done by Chavda et al., so at King's College London. And what they looked at was teeth that they suspected had cracks. They took a PA and they took a CBCT, and then they extracted the tooth, and then they found out, was there actually a fracture in the tooth or not? And what they found out was cone beam CT and periapical radiographs have significant limitations in detecting vertical root fractures. So not big fractures, I'm talking about fine fractures. But the one benefit that cone beam CT can show is they may show if there is fine bone loss associated with that fracture line. So there is, some benefit in taking it, but don't expect to see very fine fractures from it. So moving on now, that brings us nicely to the limitations of cone beam CT. And the first is beam hardening. So when we take a cone beam CT and there are metal restorations or posts or gutta perca implants that are close to the site, we get this sort of star beam hardening sort of appearance, and it really does obscure the vision that we're able to see. The beam hardening effect has been reduced in a lot of the newer softwares. So I know the Dentsply Sirona software has something inbuilt, which I'm sure Graham can talk to you a little bit about later, that reduces the effect of beam hardening, but it is definitely a significant limitation on what we can see. Cone beam CT also has a lower spatial resolution than periapical radiographs, and therefore that's why we struggle to see very fine fractures and fine instruments that have fractured as well inside the root canal system. Also, the scan time is about 20 seconds, so children may struggle with this, elderly patients may struggle, and anyone with any neurological disturbances may also struggle just being still, because the quality of the cone beam is significantly reduced if the patient moves during the scan. Moving on to the benefit of cone beam with endodontic complications. So this was a patient that was referred to me for the root canal treatment of upper left 1. He had the treatment done many years ago, but he was now developing problems with it. So immediately when we look at the cone beam with the periapical radiograph, we can see that the root filling is slightly off course. What does that mean? I mean, it's very difficult to know what to expect until we have a cone beam CT. So you can see here, that root filling is completely off course. It's actually caused a perforation buccally. And you can see this is the true root canal centered within the root. So immediately I know when I'm encountering this case, I learned from my mistake from the previous one, take a cone beam CT so we can see exactly what's going on. And I know that, look, there's a very obvious root canal there. It shouldn't be a problem to find. And I'm going to have to be prepared to mend this buccal perforation. The other important knowledge it tells us is there is a buccal perforation, but there is no lesion associated with that buccal perforation. So that improves the prognosis. The main lesion is associated with the root canal. So this was when I carried the treatment out. You can see here, this is initially, I can see that's the GP that's been placed in the perforation site. I removed it. This is the perforation site here, and this is where the true canal is located. So I know that the perforation is buccal, so I'm looking for the canal slightly more palatally. And I've mended the perforation site with MTA, and here I've obturated the main canal. And you can see at the 1-year review, the periapical lesion has healed completely. The next big reason to take it is pre-surgical assessment. So for endodontic surgery, this is a must. I really think a cone beam CT is so important prior to considering endodontic surgery. It allows us to treatment plan better. It allows us to see exactly where the periapical lesion is, what size it is, and its relationship to other structures in the body. So if we have a look at this case together, this was a patient that was referred for the management of the lower left 2. It was tender to percussion, tender with buccal palpation. There was no abnormal periodontal pocketing, and the crown was fitting quite well. So we have a decision to make. Should we do root canal retreatment or should we do endodontic surgery? Now, for this case, normally I would, want to do root canal retreatment when the root canal hasn't been done very well. But in this case, what I did was I did apical surgery, purely because the crown fit very well. And you can see that the post inside the tooth is very, very large. If I try and dismantle this tooth, there is a significant chance it will fracture and this tooth might be unrestorable. So we went for endodontic surgery. So in terms of the cone beam CT, these are the slices that are present. And we can see loads of information before attempting the surgery. So what we can see is the buccal plate is intact. You can see on the axial slice and the slice on the first one. So I know that I'm going to have to drill into the bone in order to access the lesion. So I'm prepared for this. I can see that the lingual plate is intact. So it means that I can scrape this lesion on the lingual aspect without worrying that this is going to perforate through and cause damage to the lingual mucosa. And I can also see that the lesion is very, very large and it's surrounding the adjacent teeth around the apices. So I know that I have to be a little bit more careful when curettaging this lesion, not to devitalize the adjacent teeth. So it's given me a lot of information prior to even doing anything for the patient. And also I can consent the patient to all the risks as well with this information. So this was post-operative, and you can see I've done a slightly longer retro preparation, and I've got a 1-year radiograph and it had healed completely. So the right decision for this patient. If we look at a slightly more complex surgical case next. So this was a lady that was referred to me because of an abscess in the furcation of the lower right 6. She'd had the root canal treatment done quite a few years ago. It was tender to percussion, tender to buccal palpation. The crown fit again very, very well, and there was no abnormal periodontal pocketing associated. So my first look at when I see this radiograph is there a vertical root fracture? We can see that there's a J-shaped radiolucency associated with the tooth, and there are 2 large fiber posts associated with the mesial canals. So in terms of having a look, I didn't want to do a root canal retreatment in this case because removing that probably is going to be unrestorable, because the dentist has felt that they had to put obviously 2 large fiber posts in order to retain that core. And so there's unlikely to be very much tooth left underneath that crown, first of all. And second of all, it's going to be a real, really difficult and really destructive to remove those fiber posts. So if there's any option here, it's either an extraction or potentially root canal apical surgery. So I did tell her, we can take a cone beam CT, but we may see that there's likely a vertical root fracture present. So we did a cone beam CT. I'm just going to show you the scan. So you can see that there's a lesion associated with the mesial root and the distal root. And as we slide down that, I can see that. I can see that the ID canal is fairly low and it's fairly far away from this tooth. So apical surgery would be an option here. Again, you can see the ID canal very far away from this root as I'm flicking through this image. And then as we flick through the axial slice in a second, you can see there are no missed root canals. And what we can see is the buccal bone is very, very thick. So the lesion's actually mainly centered around the base of this tooth. So this is the ID nerve. We've got a good amount of bone present before we reach the roots. This is the lesion. So the lesion has started here, and because the buccal bone's quite thick, it's drained higher up into the furcation area. So the J-shaped radiolucency is actually mimicking a fracture. There's no fracture, or there's unlikely a fracture here. The reason the abscess is draining high up and we've got a J-shaped radiolucency is because the buccal bone is very, very thick and infection likes to drain through the easiest path, the path of least resistance, and that's why it's gone up like this. So this is the slices that we're seeing here. We can see that the mental foramen is fairly far away from the root canal, the roots and the root canal. The ID nerve is fairly far away, and we've got a large lesion associated with the base of this tooth. I can measure the thickness of the buccal bone, and therefore I can relate, I know exactly when I'm going to be reaching the lesion. And I can also see I've got a thick lingual plate. So if I'm going to be curettaging this lesion, I'm not worried about going in and disturbing the lingual artery because, we've got a good thickness of the lingual plate. This is straight after the root canal surgery, and I saw this patient actually last week for a 3-month review, and the lesion's healing beautifully, which is great. One of the next reasons we use cone beam CT is to look at resorption. So both internal resorption and external resorption. Resorption is a huge topic, so I'm going to be just going through one case on external cervical root resorption. So this was a patient that presented from her dentist. She had a GIC restoration close to the cervical margin here, and she was getting pain from the tooth and symptoms of irreversible pulpitis. So if we look at the radiograph together, we can see, okay, there's a large GIC restoration present, and we've got these striations which are working their way up the root. So my initial thought was that the external cervical root resorption has spread up the root surface, and most likely this tooth is unrestorable. Now, bear in mind, this young girl was, I think she was 14 or 15 at the time she presented to me. So she's got a long way to go before she can consider an implant. So I was really keen to save this for her. So I took a cone beam CT, and what you can see is that on the periapical radiograph, we couldn't see anything to do with this severe dilaceration. So the striations on that root were not to do with the resorption, but we're seeing the superimposition of this dilaceration. However, we have got recurrent resorption underneath the restoration, which we can see on the axial view here, and it has penetrated into pulp. So I decided to repair this case. The cone beam CT quite significantly changed my management because what I decided is because of the dilaceration, I was going to access the root canal buccally through the resorption and do the root canal this way. Because if I'd gone in palatally, actually there would be hardly any tooth left. So I raised a full thickness flap, removed the restoration, cleaned out the granulation tissue that was there, and restored the tooth. And that patient, I saw her for her, I think her 1 or 2 year review recently, and she's doing really well. I suspect she'll keep this tooth for a very, very long time. In terms of evidence, this is a paper that I published during my postgraduate training. And what I looked at was, is a cone beam CT necessary for the management of external cervical root resorption? So I looked at periapical radiographs and compared them to parallax radiographs and compared them to cone beam CT. So we showed them to many endodontists and many postgraduate endodontic trainees. And what we found was that periapical radiographs were significantly less sensitive and specific in detecting the lesion. They significantly underestimated the size of the lesion. We couldn't really see how far the lesion had spread circumferentially around the root canal system or where the lesion was located on the root surface. And most importantly, when the clinician had a cone beam CT available, their treatment plan changed significantly compared to when they didn't have a cone beam CT available. So we really, for external cervical root resorption, we should be taking cone beam CT prior to considering the management here. The last point that I'm going to go through is dentoalveolar trauma. So this case was kindly given to me by Professor Shannon Patel and by Aram Navai, and it's a trauma case. So this patient presented to Shannon in practice. They had trauma, and the main thing that was sort of standing out was the mobility of the upper right tooth. Now, if we look at this, we can see, okay, there's a significant fracture of the upper right tooth. But if we take a cone beam CT, we could very easily have missed the fracture on the upper right one. And we can see that the fractures are actually really quite severe. So they start fairly high up on the root surface in the mid-root, but they are oblique fractures and they end, very close to the palatal tissue here. So does that change our treatment plan? Well, firstly, we might not have detected the fracture on upper right 1, so that would be a significant problem. But also, we know that when we have fractures like this, we need to reposition them and splint them. If a fracture is in the apical or mid-third, we splint it for 4 weeks. And if it's in the cervical third, we splint it for 4 months. Now, if we have a look at the fracture here, okay, this fracture, which is probably what we are detecting on the radiograph, would probably think to splint these teeth for 4 weeks. But actually, because of the oblique nature, we should be splinting this for 4 months because it has extended to the cervical third. So it significantly changes the treatment plan here. In terms of evidence, this paper looked at exactly that. They looked at fractures and they found that cone beam CT made a significant difference in the location and angulation of detection of the root fracture. So again, lots of evidence surrounding the topic. Now, cone beam CT has been around for a long time, and so we mainly know about it in the context of implants. But for endo, it makes, the quality of a cone beam makes a significant difference because endodontists, we look at tiny, tiny little things. So we need to have a really good quality scan in order to treat the tooth successfully. A lot of the images that I showed you, they were scans that were taken in HD mode, so high definition mode. And for me, an HD scan is sort of almost essential in endodontics. I can probably just about work from an implant scan or a low definition scan. I can roughly see how many roots they have, but all those fine details on canal curvatures, do the canals join together, how far has the resorption truly spread, all of those questions mean that I need an HD scan. So the machine, I've bought a Dentsply Sirona Orthofos SL in practice, and it really was a big decision on which scanner I was going to buy because I was looking at something that sort of produced the quality that I needed to have. It's important that the field of view of your scanner is small because a 5x5 scan has a much better resolution compared to big scans. So for example, 8x8. So for endodontics, we really want a very small field of view because it improves the resolution. It also reduces the dose to the patient because we don't need to scan large areas in order to, for endodontics, we need to scan small areas. So I just want to show you a typical cone beam CT scan. This is a scan that I got sent by a referring dentist, and you can see the quality of this scan compared to the images that I've been showing you. I mean, it's an okay scan. It would be, I'm sure, very great for implants, anything MaxFax related, but not that good for endodontics. I just can't see the anatomy and the detail that I want to see it. So this is a standard definition scan on the Orthofos SL. So it's fairly good. I can see what I want to see. What I'm looking at here is a 3-rooted premolar. I can see, okay, there's, more than one root here. It's fairly close to the ID nerve. I'm looking through the images, not loads and loads of detail. It's okay. And if I look through the axial slice, you'll see sort of the real sort of problem that I have. As I sort of scan down it, what we're looking at here, okay, there is probably two buccal roots here and one lingual root, but I can't really see what's going on with that root canal anatomy. So it's okay. I would probably have enough information to treat this tooth. But in reality, what I really want is a high definition scan. So it's a slightly higher dose of radiation for the patient. But to be honest, it's nothing compared to a medical CT scan or anything like that. And as I sort of scroll down, I can see exactly where that resorption is. I know what I'm treating. I'm confident in what I'm treating. So for me, a high definition scan for endodontics is really important. And you can see pretty much with all the anatomy here, I can see exactly what I'm going to face. Now I'm going to finish on the benefits of a cone beam CT for me personally and for the patient. So having a cone beam in-house, for the patient, it means that they don't have to travel. So I used to refer my patients out, which meant, they would always roll their eyes at me when I said I needed a cone beam CT, and they'd be like, oh, do you have to have one? So I think the travel is a real nuisance for a patient. It delays the treatment. So it means that instead of doing the treatment straight away or next week, it means that I'm waiting for them to go and have the cone beam CT. Then I'm going to book a review appointment so I can discuss the cone beam CT, and then I have to book treatment. So it increases the number of appointments both for me and for them. And therefore, sometimes I didn't used to order a cone beam CT. I used to say, okay, let's try. If we really need one, then I'll order it. So potentially it can affect quality of care as well. For me as a clinician, it was paperwork. So I had to fill out a referral form in order to get that sent over. The time again for me to do that. I noticed that some patients just wouldn't come back. So I would send them for a cone beam CT. Life gets in the way. They would forget to have it done, and then time would pass, and they'd come back like a year later. Oh, I know you told me to get a scan. So in terms of patient loss, there is that sort of aspect as well, and therefore it can affect the financials of things. So thank you very much. I'm going to hand back over to Adam. Stop sharing that. Adam, I think you're on mute still. So I hope you guys found that interesting. I'm going to talk a little bit later at the end of the presentation about something that I've been trialing for Dentsply Sirona. So you can hopefully stay tuned for that. It's something quite exciting that they're launching soon. And if you guys have any questions, please let me know and I'll answer them at the end of the presentation. It's been great. Thanks so much, for all of you tuning in.
Kreena, thank you ever so much for your presentation. That was fantastic. For everybody that hasn't yet looked in the chat, I have put a couple of links down there for Adam's social media profile and Kreena's as well. So if you'd like to learn more about the work that Kreena's doing, her Facebook profile is down there. Adam, I think we've got you back now.
Yeah, I'd lost some buttons, so apologies there. Thank you, Kreena. That was absolutely fantastic. Seeing some of those cases and sort of, what you couldn't see without CBCT is absolutely enlightening. Before we carry on this evening, what I just wanted to quickly do is just share some interesting information from the survey that everybody filled out at the start of tonight's session. And it's really, really quite fascinating to see that across the sort of how long people have been practicing as a dentist, we've got a really, really wide and quite even split of experience within the room tonight. But really interestingly is, even though we've got that massive, massive split, almost everybody, so 76% of you, joined with an interest to learn more about digital technologies and how they're going to help you in practice. So I hope that, myself and Kreena and Graham, as we go on, will be sort of answering what you wanted to learn. So what we're going to look up next tonight is how to consider, what to consider when looking at imaging solutions, some kind of information to maybe ask manufacturers, and to think about as you look to make that decision with your practice. So how do you pick the right imaging solution? So as I said, it's what questions to be asking. Let's think about some of those key considerations. So when it comes to quality of your imaging solution, some of the key things to be sort of considering and asking about is how efficient is the low dose mode of the different machines available? So at low dose, are you still getting a good enough image quality to be able to carry out the diagnosis? does the machine have the features and functions you want? So if you're going to be using it for 2D imaging as well as 3D, do you have dedicated sensors in there, sort of, you know, providing that key information for you? And Kreena sort of touched on the topic of metal artifact reduction software. And we will in fact be looking at that in a little bit more detail as the evening goes on. So when we think about the quality of the product itself, you know, when you're looking, think about, you know, is this a reputable manufacturer? You know, think about the companies that you work with in your surgery already and within the practice. Is it somebody you already know from other products within the surgery environment? Think about the stability and the kind of build and everything of the scanner as well. You know, this is a machine that's going to be lasting you a number of years. So again, think about, you know, is it going to last the 10, 15 years that you want it to? And what technical and education support is available? You know, both when you have the system installed and also moving forward, is there education there to support you on your journey as you grow your practice around the technology that you've invested in? So if we also think about how these things affect the image quality as well. So, you know, if you're going to be using the system for low dose for other things as well as endo, have a look at the image quality. Think about patient positioning. You know, this is something which is key when it comes to getting a good image out of any CBCT solution. You can have the highest resolution of any machine on the market. If the patient moves or isn't positioned correctly, you're not going to have a good image. So take that into consideration as well. And whether that image is going to give you the clinical confidence that you want and that you need to make your diagnosis. We've seen from Kreena's presentation just now, and also from the clinical studies we looked at the start of this evening's session, what can be missed without the right good quality image. So they're all things to think about when you're considering your investment and your next move. Now, all of these things as well have a factor on the quality of the treatment. In terms of whether the treatment's going to fail, whether you're going to manage to treat, you know, every route that's there that you've been able to now find. What's the patient experience during the scan? You know, there should be something that's pleasant and quick and easy to do. It shouldn't be something that's, you know, sort of laborious. And with that scan, once you've got that good quality image, like we've been seeing from Kreena's cases just there, you know, is that also helping you communicate with your patient and get their consent for the treatment? And think about, you know, if you don't have this technology and you are referring, you know, Kreena mentioned there that, you know, patients don't necessarily like that being referred elsewhere. You know, what's the cost of potentially losing patients in the practice as well? So that's one area to consider. And then we also want to think about the ease of use. You know, we talked about the dedicated sensors and the patient positioning. Now, how easy is that? When you look at sort of modern machines today, what you'll find is options like some patented technology that will help you with auto positioners that will get that patient lined up and avoid the need for having to have the 3 traditional laser lights. All things which again are just, you know, that ease of use is helping you get that better image quality and of course resulting in a higher quality of treatment as well. Think about the software integration. You know, is the software nice and easy to use? Is it intuitive that guides you through step by step? Or is it something that's quite difficult and is going to take a lot of time to get everybody up to speed in? And what are the features? You know, are there features there that you want to use? And again, I go back to training. You need to make sure that all the staff that are going to be using the machine and the software are going to get the required training from whoever you choose to invest with as your partner in this journey. Now, when of course it comes to sort of, you know, managing sort of errors and things like that, It's, is the quality of your image allowing you to make the correct diagnosis? Are you fully informed on what you need to see to gain the benefits of both the clinical studies that we looked at earlier on this evening, and also that Kreena's shown us through her presentation tonight? Now, again, practice integration. We want to be thinking about how the software works. Is everything integrated into one seamless workflow? So if you are getting metal artifact reduction, is it built into your imaging software? Is it kind of an automated process? Or is this something you're having to add on potentially at extra cost as well? And more about that whole digital workflow. It's not necessarily just about the CBCT scan. It's how's the software going to integrate with your digital impression scanner? Or if you're going down a sort of full chairside solution with milling as well, will your CBCTs talk seamlessly, or are you having to get third-party pieces of software involved as well? And it's not just with other technology. It's also think about that 2D imaging with your intraoral scans, as well as potentially PANS and KEFs. Can you view all of this in the same screen to make your life easier? Does it integrate with your practice management software? And also, are there options as well, or does it include things for other treatments within your practice? We've already seen how a CBCT is going to massively help with endo treatments, but where you're offering implants in a practice, is there integrated implant planning software, or are you needing to export all your scans to a third-party program to be able to achieve that sort of thing? And then when it comes to analysing the image, it's kind of what we've been talking about. It's having everything together in one screen, one piece of software, just to help you provide all the benefits we've talked about tonight. And what added sort of software tools are there? We're going to see some really interesting tools with Graham shortly that will sort of just help you with the endo treatments. So is it integrated? What's available to you as an option? And then, of course, when it comes into that patient experience, again, there's been studies carried out here. So, you probably know already, treatment failures like failed root canal treatments can quite often lead to the loss of a patient from your practice. So according to the surveys, 26% of those people that choose not to visit a dentist blame a previously bad experience. And as well as, not wanting to sort of, have your patients suffering at all, there's a financial implication to patients' dissatisfaction. And it's not just financial, it's also, when it comes to referrals, with 50% of a practice's new business coming through word of mouth. You don't want patients to be having a bad experience with you or any of your treatments. Now, what I'm going to do next is hand over to my colleague, Graham Parker, who's going to give us a short demonstration of how software can work seamlessly alongside the hardware in your practice to assist you with those more complex diagnosis and clinical studies that we've looked at earlier this evening. So, Graham, you should be ready to take over at this point.
I am, Adam, I am. Brilliant. Okay. Right, am I all visible to everybody?
You sure are.
Super. Well, thanks guys for sticking this far. I've just had a request on the chat, but I'm staying, sorry. Right, so I'm just going to quickly run through the Sodexis software. Essentially, Sodexis is a digital imaging database for images. And this, again, as Adam had just said, will link into your, hopefully, your practice management software. It should do that seamlessly. Then every single managed practice management software in the market is able to link in with this software. If you have a practice management software that say they can't, we can provide a software development kit will allow them to do that. Starting off on the software, all your images in the Sodexis software are stored in a data sheet like this. You can just scroll through it like the old Rolodexes, and all the images for that particular patient are stored here, and you can just pull them out as and when required.
Graham, should we be seeing your screen?
Yes, you should. Yep. Right, so let me, there's a little button there that says share. Sorry, guys. Yeah, so let me, thanks for the heads up, Ian. Yeah, so it's my little Rolodex system here for pulling up images. They're all done in date format, so past and present images can be pulled up at your leisure.
Back with us. Oh,
Yeah, can you hear me, guys?
Yes.
Yeah, good. Yeah, so patient information is all stored here as well in terms of images. For instance, we can store pan images, we can store PAs, radio volumetric images, and intraoral camera images as well. So we can import images. Sorry. We can import patient images through the exposure file. So it accepts all sorts of images in terms of DICOM, DCM files, all types of graphic images. You can integrate your intraoral camera here as well. And in terms of output, we can output a viewer file. So if you have a referring dentist who doesn't have a scanner or doesn't have the software, we can actually export one of these scans in a viewing format so they can do basic measurements, etc. Right, so we're going to have a look at some images now. So the first image we're going to have a quick look at is the panoramic image. We've got an SL image here, and one of the key advantages of having a digital imaging software is that the image that you see is not always the image that you get. With a film, once you've taken the image, you're kind of stuck with the exposure factors. With a digital image, as you're probably all aware anyway by now in 2021, that we can actually change the characteristics of the image. So if you've overexposed or underexposed, you can actually highlight certain features on the image. So for instance, this image here, it's not the perfect image, so we actually use real images when we do our demos. The tongue isn't at the roof of the mouth, and so what we get here is kind of like an apical burnout. But using the software, we can actually counter for that and bring the values up so we can see the APCs quite clearly. Other tools on here we have our sharpness filter. It just hardens up the edges a little bit. It makes the image a little more pleasing. And although we've got loads of tools on here, perhaps the main ones we use are the sharpness filter and the invert image filter. So this is something a radiologist would use all the time in his practice. Oops. So just bring that down. And when you're examining your images, whether it's 3D or 2D, it's kind of a nice thing to do to actually just flip through invert video, because it does bring up different aspects of the image for you to assess. So if you go back into our, let's wait for my window to get out of the way. There we go. Yeah, so we'll have a quick look at a 3D image now. And we're not going to look at that one, we're going to look at this one first. This one is Kreena shows some high definition images here. I'm going to show this is a 5x5 field of view. Navigation is really simple, and even if you've never used digital software before, inside about 20 minutes you'll soon get the hang of using this. So basically with our software, basically just click on a particular point, follow the arrows on the screen, so make that full size so you can see it, and you can zoom in. Not that one. Yeah, so just follow the arrows on the screen. They can navigate buccal-lingually through the image, and you see all the corresponding windows will actually follow what you're doing in these windows, and each image was the same. So as you hold the mouse in the windows, follow the images, it will navigate through the image. So it's very easy and intuitive to learn how to use this software. Again, with the 3D software, we have the various filters and adjustment tools. We do have the ability to switch to MPR mode, multiplanar radiology mode. And this is probably the software that you'd use for your reporting. So you can navigate in the superior inferior view through the image, and double click on a particular point that you're interested in, and the other images will follow suit. In terms of the software, one of the key benefits of this software is the fact that it's great for patient communication. So although we have a panoramic image here, as we know, panoramic images are great for overviews, but not necessarily accurate or diagnostic. We also have a 3D rendered view here as well, which is, again, basically more for patient communication. All the real work is done in the MPR view or maybe in the endo view when you're lining up anatomy to measure or evaluate. So what I want to do here is actually show you, this is an 80 micron image, high definition image. It takes it's 500 shots within 14 seconds. Ideally, that's what you'd be using for endo. I'm going to show you another image here. This is a HD image. This is an 11 by 10 view. The resolution on this is 220. And if I compare the two images, it's there is a difference in image quality, but not much. And the reason being is that the build quality of the machine. Our units have twin columns. They're built like brick outhouses, thanks to our German engineering. And the analogy I like to use is that if you've got the most expensive camera in the world and you stick it on a tripod that you've bought in Woolworths, they don't exist anymore, you're not going to get a very stable image. And one of the key features of our machines is that they are actually built rock solid. And it's really important that when you think about taking a scan, when you purchase a machine, sorry, you think about the image chain. So I don't know if you ever heard this in your training, your college days, but it's really important that when you're taking a scan, first of all, you need to have all your ducks in a row, really, when you use an X-ray. So you need to justify that you're actually do need to scan, but the technique or position of the patient is paramount in these machines when using these machines. If you get the technique wrong, you're going to mess up your imaging. And half the complaints that me and Adam will get is because the end user hasn't been trained correctly. So it's really important that you get good training and positioning technique with these units. And again, it's having the best sensor in the world and having the best tube head in the world. Unless you've got these protocols in order, you're not going to get the best imaging. For instance, the training that you need to use these machines for the operators in surgery and the guidelines for the safe use of cone beam dentistry is 6 hours. We come with a variety of tools which you need to learn how to use. You need to get the dose correct, and you need to get the resolution on your screen correct as well. So you need to have good quality screens to make sure that you get the best out of your machine. So with that, I'm going to switch over to some of the new software from our partners, CCAT. Wait for this screen to disappear. There we go. So, yeah, so we have the ability with our CCAT partners to be able to map your root canal. So I'm going to have a quick example here. So here you can see our image here. Also, if I go to prepare, we can also, it's actually working on here now, never mind. We go to diagnosis, and what we're going to do is map some canals. So the first thing I want to do is align up the area we want to do is select next.
I think we're having some issues with Graham. Graham, I think we're having some streaming issues there. Adam, are you?
Okay, I'm back. Can you see the screen again?
No.
Right, 1 sec. Get back onto that. Okay, I think I'm back. Right, so we're going to map a canal. First, I'm going to select the area I want to map. So this tooth here, and I'm going to click on this point here. And I can switch from window to window depending what's the easiest for you to use. And you can see on this window here at the bottom there, I can actually navigate around and see the path I've just mapped. And if I need to make any adjustments, I can do that. I can add some extra points on if I need to. And bring this up to the top of the crown. So I can either map another canal. I won't do that at the moment because I think the connection might be a little bit flaky, but if I go to next, I can decide to add on a drill path, a planar drill canal. And to do that, I click on here like so, and you can see I can bring my access channel down into the canal like so. I can adjust it. Like so, and when I'm happy with that, I can click finish. And in our 3D rendered view, you can see, let's just get rid of that. You can see your access path in the actual tooth. So this can be then you can actually do this in front of your patient. So it's a great treatment advice tool for your patient and to try and get them to commit to the treatment. It's like Star Wars when you do this in front of a patient, and they're more than likely going to agree with the treatment plan. They're generally not going to go anywhere else. From here, you can then add some notes. You can actually print this out or copy it, print this out and give it to your patient, or keep it in a file. And it makes the whole experience for both you, building confidence in you and the treatment you're going to do, but also together with your patient, it means that you're going to have a happier, more satisfied patient, and manage to keep the patient, essentially, I guess, in terms of showing them what the type of treatment they're going to have. Yeah, from here you can then output it. You can actually develop a surgical guide, if you like, for endo together with CCAT, and that is a possibility, or just to aid your planning your treatment in-house. So yeah, I think back over to you, Adam. I think that's probably enough on this before it packs up again.
Thank you, Graham. I think your connection just about lasted with us there to the end of that that demo.
Thanks.
Hopefully, John, if you can give me a thumbs up that my screen's back sharing there. Brilliant. So we're just going to move on from there to, I think it was the last item that was on the agenda, but not the actual last item for the evening, because obviously we're going to be returning to Kreena as well tonight for her exciting extra bit of the presentation. But to start with, what I'd like to just do is spend a couple of minutes just talking to you about your digital journey with Dentsply Sirona. Now, in terms of, so obviously we've seen all the way through tonight through where the market's going, where dentistry is going through the studies that have been carried out, and also from the results that Kreena is able to achieve, and some of the potential pitfalls that Kreena's highlighted tonight, and again have come up through those clinical studies of sort of where we need to be heading. So I just want to, as I say, go through a few bits of information with you about the company and how Dentsply Sirona, as the global leading manufacturer of dental equipment and supplies all across the world, can partner with you on that digital journey with CBCT. So here's some numbers to look at first. So as a company, we've got a total revenue of about $4 billion US. And you'll see from the graph here, that's fairly evenly shared across the world. So we're present in over 40 locations worldwide. Our main head office is in Charlotte in the US, but the equipment that we've talked about tonight, and you may have seen on some of our other sessions, is actually manufactured in Bensheim in Germany, hence our reputation for solid German engineered products. Here in the UK, we're actually based in Weybridge in Surrey, where once the current situation eases, we can't wait to welcome you all back to our showroom and to all of our hands-on education programs that we run at our UK Academy. But we're all very proud here in the UK to be part of a 15,000 strong global Dentsply Sirona team that's here to sort of help you in practices. So when we look at, our vision, our purpose and mission is actually to every day empower dental professionals like yourselves all over the world to provide millions of patients with better dental care. And more importantly, it's to make people smile. So we empower that through innovation as the global technology and innovation leader in the dental industry. So we actually spend over $150 million a year to advance dentistry. And with over 600 scientists and engineers, we've got the largest R&D platform in the industry. And all of this is geared towards empowering you to provide safer, faster, better dentistry for your patients. So as that global technology and innovation leader, we've got a solution for every workflow and for every customer need. Now, obviously, when we finish this evening, after we've been back to Kreena in a few moments, what you can do to get more information from myself or Graham is if you go onto our website at dentsplysirona.com, you'll be able to book a one-to-one consultation, and that can be on digital imaging or on any of our other workflows and pioneering products that you can see here. All you need to do is click on the relevant image, so digital imaging, and you'll be able to book a session with, as I said, myself or Graham, or any of our colleagues and product specialists in the other areas. So as our evening starts to head towards its close, I'd like at this point to hand back to Kreena, who will put us out of our suspense and tell us some exciting news you've been keen to share this evening.
Thanks, Adam, for handing back over, and thank you both for such wonderful presentations. I'm sure I've learned quite a lot from the demo of the software as well. So really, I wanted to talk to you about how endodontics is going. We are moving towards more conservative endodontics throughout the whole procedure. So right from access cavities, where we're trying to make our access cavity smaller, more conservative, right through preserving dentine through our preparation. So Dentsply Sirona asked me to trial a new file system called True Anatomy. A lot of you may have heard about it, but I just really wanted to give you a little bit of my feedback about this new file system. So there are three main sort of files involved in this. There's the orifice modifier, which is very similar to an orifice opener, but a lot more conservative. There's the glider files, and then there are the shaper files. And I think it's a fantastic system. It really does preserve a lot more tooth tissue, and we know that trying to preserve more tooth tissue may have big implications in terms of preventing a root-filled tooth from breaking or cracking in the future. What I really loved about the file system was that it was sort of incredibly flexible, and I guess I know John shared some sort of feedback on my Instagram, but if you have a look at some of the really curved cases I've done, a lot of them have been the True Anatomy file system. So I'm just really excited about the launch, and I'm told that it's going to be launched fairly soon this year. So look out for that later on this year from Dentsply Sirona.
Thank you, Kreena. So yeah, that's something else exciting to look forward to from us a little bit later this year. Keep an eye on social media and our website as well for more information on True Anatomy. So our time together this evening is, coming towards the end. Thank you very much for attending this evening, and thank you especially to our guest speaker tonight, to Kreena Patel. I know John has shared some social media links, so you'll be able to follow her as this journey progresses. Don't forget the next topic as well that we're going to be covering in our Let's Talk series is going to be digital diagnostics and CBCT in the implant workflow. And you'll be able to register for that just the same way as you did for tonight's session on dentsplycerona.com. And on that, we're going to open up for any questions that you might have that you want to pop into the chat. And we'll try and cover any questions that you've answered already this evening. So, John, are there any questions first that we need to cover from earlier on?
Yeah, so probably the biggest question I would imagine of the evening came from Derek, who said, could you justify a CBCT for all endo? This was then followed on with a number of comments from other delegates that kind of all agreed that it probably is in most cases. So, Kreena, it'd be great to get your thoughts on that question.
Yeah, I mean, it's a mixed feel in the endodontic community. A lot of endodontists do take a cone beam for every endodontic case, and they liken it to a roadmap. So the CBCT provides a roadmap for what you're going to be treating. So I think you can justify it for pretty much every case. Do I take it for every case? No, I don't. So I don't take it for every single case. I'm taking it for more cases than I ever have before, now that I have easy access to it. And having taken it, I've realized actually there is a fantastic sort of need for it. So it might become, I think, with time, something that we take for every case. But at the moment, I take it for anything that's slightly complex.
Perfect. Thank you, Kreena. So if I just pull up some of the other questions, there's a question here from Fide. If I have a Sirona CBCT for implant purposes, will it be easy to change to HD mode? Kreena, I know you spoke about using HD mode.
I mean, I can tell you about my, Graham or Adam might be better at answering this, but for me, we have implants in our practice as well. And for me, it's as simple as pressing a button which says HD or SD. So it's really, really simple. My nurse actually sets up every sort of all the settings right before I come and take the scan with my patient. So it's so simple that obviously she's only just started working with me, and she's already got to grips with it. It's really, really straightforward on the machine.
Perfect. Thank you. There was a comment from Vanessa saying she does always use HD mode. There was a question.
Endo, it's just one of those things. I know a lot of people do use standard definition, but I think for endo, you really want the detail of it. You want it to impact your treatment. You want it, you want to know, is there an extra canal there? Where is that extra canal? What's the curvature? So I really think, I mean, I would never take an endo scan that wasn't an HD scan.
Thank you. There is quite a specific question from Kareem, which I think we'll come back to. I don't know if you can see that in the chat, but we'll give it a couple of minutes for you to have a look at that, because it's very specific around voxel size and the very specific settings on HD. So we'll come back to that. But before we do, we've got a question from John, who he asks various enhancing programs that claim to enhance lower quality scans. Now, Adam, I know you talk a lot about low dose, so maybe that's one that you want to comment on.
I was actually going to hand over to Graham on that one.
Ah, perfect. Graham, over to you.
Yeah. So low dose imaging is tailored for specific mediums. So you wouldn't use low dose on an endodontic case, but as a secondary finding, a low dose in endodontics, a low dose could be useful. Generally, low dose will be used for perhaps orthodontics or for implant planning. Yeah. So the implant planning, all you need to see is the height, the depth, the width, perhaps where the ID canal is. So low dose is ideal for that. For endo, like Kreena said, really you're looking for as much detail as you can. So high definition is the way to go. And that's what the guidelines say as well. That's in the studies that I think Shannon Patel did a couple of years back.
Thank you, Graham. So again, just to come back to that question from Kareem, for the HD CBCTs you take, what are the settings, voxel size, etc.? Are we able to answer any specifics on that? Yeah,
there's for the SL, we're looking at 80 microns for the high definition mode in fiber 5. For the 8x8, we're looking at 160, and for 11x10, we're looking at 220 microns, but you saw the difference between the 18 and 220 microns there. There is a slight difference, but it's really not much. It's not all about it's not all about the resolution. It's more about the whole process, the whole, the machine, the sensors, the quality of the machine, the quality of your positioning the patient, the quality of the screens you use. Is a whole imaging chain that you need to be aware of. So it's not all about the size of or the resolution.
Thanks, Graham.
So
I think that's everything from the chat in terms of questions, Adam.
that's fantastic. Thank you, John. So we'll just sort of finish tonight by saying a big thank you to everybody for spending time with us. Thank you again to Kreena for joining us tonight. And thank you, John and Graham and Ian, for being there on standby as well in case you were needed this evening. So, we all really hope that this small event has raised your interest in starting that digital journey and growing just by embracing innovation. I hope to meet you again in one of the many events and reunions that we usually organise for our customers. And I hope we can be part of your digital journey. So I wish you all a good evening and good night.